Now, our next speaker will be Dr. Khalifa Al-Shaiji. Dr. Khalifa Al-Shaiji is a neurologist at Jaber Al-Ahmed Hospital. He did his medical school in Kuwait, and he is a graduate of the Kuwaiti Neurology program. He's one of the excellent speakers and one of the excellent actually neurologists in Kuwait. And Dr. Khalifa will talk to us about update and management of migraine. So with that, I'll leave the floor for Dr. Khalifa. Switch my internet. Where's it? So, this is update. Sorry. Okay, to switch slide. Okay, just check. So, tell me when to start. Okay, let's start. Okay, good morning, everyone. Today, I'm going to talk about the updates and the management of migraine that's happened in the past few years. I'll try to cover as much as I can regarding the new era of the management of migraine. So these are the objective of my talk. We know that migraine is one of the most commonly encountered neurological complaint in our practice. It's classified as episodic or chronic, and each type further subdivided depending whether they contain aura or not. It's more prevalent in female, and around 90% of patients have a positive family history. And usually the big prevalence between the age of between 35 to 39.
migraine is a leading cause of disability. And this fact was well demonstrated through the global burden of disease study in 2016, where it comes next to the back pain. So almost affects all aspects of the life. And despite this, it is still under-recognized and under-treated. And this also have been shown in this study that have been done by Dr. Al-Hashil in Kuwait, where they tried to find the migraine burden in Kuwait through a cross-sectional study, which included around 15,000 patients. And the one-year prevalence of migraine was 23%, which is a bit high when compared to countries in our region. Most of the patients who was labeled as having migraine through the survey seek medical help. Only 17% of them seen by a neurologist. Moreover, only 4.6% receive an official diagnosis of migraine. And this confirmed the fact that migraine is still underdiagnosed, and therefore there will be low or mistreatment or under-treatment of these patients. These are the general recommendation of subset of patients who need preventive treatment. However, as a general, you should balance between the frequency of the attack and the migraine or the attack tractability or disability. So for example, you may start a preventive treatment, or you consider starting the preventive treatment in those who are having attack less than 4 per month, but still the attack are tractable or disabled. These are the classical oral preventive treatment, which are classified according to the level. We have level A, level B, and level C, and others. And we can see here clearly that under level A, the commonly used preventive treatment, which is Topamax and Enderal, beside the onabotulinum toxin A, which was approved as a level A for chronic migraine. Then under level B, we can see the antidepressant. Then other level C, you can see the antihypertensive beside other agents. With this wide variation of choices of the preventive treatment, we have unmet need in the management of migraine. And this is one of the studies that have been studying or addressing this issue regarding the management of migraine. And through this study, they took the patient with a chronic migraine and followed them over 1 year. And only 25% will persist on their treatment at 6 months. And at 12 months, only 14% remain on their prophylactic treatment. Those who stopped their medication earlier time, a percentage of them switched or reinitiate. And at the end of 1 year, still a lower percentage continue taking this medication. And this low persistence mostly due to the low tolerability of this medication and maybe modest effect of this medication. Therefore, an attempt was done trying to find a key element in the pathophysiology of migraine or the step of the migraine itself with a good tolerability and higher efficacy. And with this attempt, they revealed they found the target, one of the targets, cyclic GRB, which is a 37 amino acid neuropeptide, which is also abundant in the nervous system, particularly in the trigeminal vascular system. It can be found in other parts of the body, like GI system, yet their clinical relevance is still unestablished. CGRB thought to regulate neurogenic inflammation, pain transmission, as well as vasodilation. The link that was found between the CGRB and migraine is that the level of the CGRB was high during the migraine attack, and then when the symptom resolved, the level normalized. Moreover, those who were given a cyclic GRB in those with susceptible patient, it triggers a migraine-like attacks. Medication that are targeting the CGRB itself or the blocking the receptor of the CGRB will also not only, decrease the CGRB level, it's also will lead to the resolution of the symptoms. These are numbers of the anti-CGRB therapies, some of them targeting the CGRB itself, the molecule itself, and other targeting the receptor. The mechanism of these therapy thought to be due to the reduce of vasodilation, reduce neurological inflammation, reduce the afferent signaling, as well as modulation of the pain transmission and modulation of pain perception. We'll start talking about the monoclonal antibodies, which is a large molecule that cannot cross blood-brain barrier. It's fully humanized and work mostly in the peripheral part of the trigeminal vascular system. The advantages of this therapy is that it has a long half-life, no hepatotoxicity, and no drug-to-drug interaction. To the date, we have only 4 FDA-approved monoclonal antibodies. The latest one is the eptinezumab, which was approved in February 2020. All of them have a similar half-life. All of them are targeting the CGRP itself, except the erenumab, which is targeting the receptor. The first 3 are giving monthly as a monthly injection through sub-Q route, and except the firminizumab can be given either as a monthly dose or every 3 months, where eptinezumab, which is only given through IV infusion, is only given also as every 3-month dose. These are the phase 3 trial for both episodic and chronic migraine. And the primary endpoint of all of these trials was a reduction in the monthly migraine days. And all of the study was significantly meeting these primary endpoints, beside most of the secondary endpoint of this study, which are a percentage of patients who receive a 50% reduction, percentage of patients who have a reduction in the acute use of a treatment, as well as improving quality of life. These are the summary of the cyclic GRB in episodic migraine. And this is one of the secondary endpoints, which is a 50% reduction. And we can see here that the monoclonal antibodies achieve this target with a significant difference when compared to the placebo. This is also a 75% target. And also the same thing with the monoclonal antibodies in the chronic migraine. So also all the monoclonal antibodies reach this target with statistical significance when compared to the placebo. So clearly, we have a good medication with good efficacy. But again, we are still wondering whether these drugs can act fast. Because one of the problems with the classical oral preventive treatment is not the tolerability issue. So also it needs time to work. And usually we tell the patient that you need to wait like 2 to 3 months to start seeing the effect. So this issue also have been addressed in the trials. And we can see in the PROMISE study for the eptinezumab in both episodic migraine and chronic migraine that the separation started as early as day 1, where we can see it in the firminizumab in the chronic migraine, where the separation point started within the first week. And this is also true with erenumab and gilcanezumab. And both of them, the separation point started within the first week. So still, we have a concern regarding some subset of patients or subgroup of patients who are refractory to the oral preventive treatments, who have a coexisting medication overuse headache. So what to do with this patient? So this is a Liberty study which addressed this issue. They studied those who have a previous history of failure of medication, and they gave them erenumab. And the primary endpoint was a 50% reduction. And the drug did not only meet the 50% reduction, it's also made the 75% reduction. It's also work fast. And this also have been true with the galcanezumab in both episodic and chronic migraine through the CONQUER study, where the primary endpoint was reduction in the MMD, and then the secondary endpoint, which also was met by a 50% reduction and 75% reduction. What about those who failed Botox? These are a post hoc analysis of patients who received galcanezumab and those who failed Botox. And clearly, we can see that the separation point started within 1 month. And there was a statistical difference between those who achieve a 50% reduction, those who have a reduction in the MMD, and those who have a reduction in the use of the acute therapy. So those who have the medication overuse headache also been studied and evaluated, especially in those with the chronic migraine. And we can see that there are statistical difference when compared to placebo. And in fact, there was no difference when we use it in both groups, whether they have medication overuse headache or no medication overuse headache. More patients achieve a 50% reduction, and more patients with the treatment with the Erinumab achieve a reduction in this in the use of the acute medication. And these also have been shown to be act as early as within 1 month. These are two meta-analyses which studied the safety profile. Overall, these medication have a good safety profile and no safety concern with a good tolerability, low discontinuation rate, which was around 2.5%. Commonly reported side effect was injection site reaction, nasopharyngitis, upper respiratory tract infection, constipation beside the other listed here. Anti-drug antibodies was also evaluated, and some of the patients who were receiving this medication developed it during the treatment. However, most of the time it was transient, and even with subsequent injection, it disappeared. These antibodies has no effect in the efficacy of the treatment. Cardiac safety also been evaluated through a randomized double-blind placebo-controlled study. They gave Erinumab in those who have a stable cardiovascular disease, and the primary endpoint is a change in the timed exercise treadmill test, which is a marker of cardiac ischemia, and they found that Erinumab has no effect in this parameter. Therefore, monoclonal antibody could be a promising option for those with a stable cardiac ischemia. In order to organize the prescription of these medication, these two society publish a guideline or consensus regarding when to start this medication. And both stated that you should consider trying this medication in those who failed at least two class A, class B preventive treatment with a proper trial of 6 weeks, or if they don't tolerate this medication for both episodic and chronic migraine. And they added with the chronic migraine that the patient need to fail at least 2 cycles of onabotulinum toxin. These are the patients you don't want to start them in the monoclonal antibodies, and the recommended duration of the treatment was 6 to 12 months. Regarding long-term data, we want to ask whether these drugs are safe in the long-term use. Is the safety maintained? Is the tolerability maintained? So these have been established with this open-label study of Erinumab of 5-year data, and it's clearly during this 5 years that there was no safety concern, low discontinuation rate, high tolerability, and no concern regarding anti-drug antibodies. Efficacy was not only maintained, but also improved with the time. And we can see that a higher percentage of patients reaching the target of 75% and 100% reduction. So at 5 years, we can say that around 50% of the patients achieve at least a 75 reduction. And even we can see some patients achieving 100% reduction of their attack. This is also have been true with the Ferminuzumab in both episodic and chronic migraine. And you can see in the graph that the efficacy is not only maintained, also improved with the time. Also with the Galcanezumab and Eptinezumab in chronic migraine. And all of these studies show no safety issue, high tolerability, and low discontinuation rate. So we can give monoclonal antibodies for those with chronic migraine and episodic migraine. We don't care if the patient have a medication overuse headache. They are safe, high tolerability, efficacy can improve with the time, and moreover, it will improve the quality of life. So this will impact your practice is that you don't care anymore to differentiate between episodic migraine and chronic migraine as you do with the Botox. You don't need to care whether the patient have a medication overuse headache or not, or you don't care to, or you don't need to bother yourself teaching or explaining to the patient how to withdraw medication overuse headache. Therefore, you can just start monoclonal antibodies and you can see that the medication that have been overused will drop out. Going or moving to the G-band, which are a small molecule antibodies that are targeting the receptor. Usually they are taken through oral route, and original study was done assessing their efficacy in the as abortive treatment, and these are the phase 3 trials assessing the yobrigimant and the rimigimant, which was meeting the primary endpoint, which is a pain freedom at 2 hours. They are highly effective. They have a high tolerability with low discontinuation rate. Those who have a cardiovascular disease or cardiovascular risk factor also have been involved in this study, and there was no cardiac concern with this study. What is interesting with these studies also that there was no risk or low risk of medication overuse, and based on this concept, this medication was evaluated as a preventive treatment, and this is a phase 2-3 trial which assesses the use of rimigimant as a preventive treatment in both episodic and chronic migraine. And we can see that the primary endpoint was met in a reduction of the MMD, as well as reaching the 50% reduction, as well as improving the quality of life. There was no safety issue. There was no low discontinuation rate, and there was no concern regarding hepatotoxicity. Atogimant is another agent which are given again through oral route. The half-life of both Gibants is around 10 hours. They assess the patient with episodic migraine with a different doses and different regimen. And again, the primary endpoint, which is a reduction in the MMD, as well as the secondary endpoint, which is a reduction of 50% or more, and even reduction in the acute therapy was all met. Safety profile was there was no issue or no concern regarding safety profile, as well as the hepatotoxicity, and there was a low discontinuation rate, and side effects usually, if it happened, it will be moderate and tolerated. The company announced a positive result of phase 3 trial of the atogimant through the advanced study, and they use 3 doses. And the primary endpoint was the MMD reduction, which was significantly met, as well as one of the secondary endpoints, which is a 50% reduction or more, and also met. And again, no safety concern, no hepatotoxicity, high tolerability. So this medication, the Gibant, are going to be approved soon for the preventive treatments. They are, as I said, effective in both abortive treatment and preventive treatment. They have short half-life. They have a good tolerability with no safety concern, and they are a good option. You may consider this patient in those who have a cardiovascular disease, who prefer or who have a needle phobia. They can be used in those who have an unplanned pregnancy or a planned pregnancy. Thank you so much.